A warm welcome to everyone to this webinar. We are MedGenome, the leaders in genetic testing in India. And today's webinar is a continuation of our one on Thursday, which was on next generation sequencing for next generation clinicians. The focus of today's topic is on the utility of NGS with a case-based approach. And our speaker again will be Dr. Sheetal Sharda, Senior Consultant Clinical Geneticist at MedGenome, who will continue with her Thursday's presentation. And to give you a brief introduction about Dr. Sheetal is a pediatrician and has done a DM in medical genetics from SGPGI Lucknow. She has worked as an associate professor in genetics in PGIMR, Chandigarh, for 8 years. She has over 14 years of experience in clinical genetics. She also has about 30 publications in national and international journals to her credit. Her areas of interest are in dysmorphology, prenatal diagnosis, and molecular diagnosis. Now, before I hand over to Dr. Sheetal, I want to inform the audience that if you have any questions or comments, please use the Q&A window of the Zoom conferencing interface to type out your questions. We have disabled the chat window for this session, so please use the Q&A window. And we got a lot of questions from our earlier webinar on Thursday. So we have incorporated, we have taken into consideration all the questions, and Dr. Sheetal has incorporated appropriate content in her presentation. So you can look out for answers for your questions in this during a presentation. And we will also be sending out a recording of this webinar in case you miss out any key points or would like to revisit some points. So without any further delay, I will now hand over the host to Dr. Sheetal, who will take this webinar forward. So over to you, Dr. Sheetal.
Hello, good afternoon, everyone, and welcome back to the second part of the presentation. And I hope that the past session is a little bit fresh in your mind. So going on to the utility of NGS, because we are all clinicians here, basically, we would like to understand the importance of NGS while sending out samples for diagnostic purpose rather than for research purposes. So first of all, as clinicians, we always have the dilemma, do you really need a molecular diagnosis? So for many genetic disorders where clinical diagnosis is quite simple, I should say, based on the clinical features or biochemical analysis, or sometimes a combination of clinical as well as certain imaging or biopsies, a molecular diagnosis is not always warranted. So you are confident about the diagnosis if based on the family history or the clinical diagnosis, you confirm it to be DMD. But in a clinical setting, molecular diagnosis is mandatory to confirm a clinical diagnosis when you know that there is a single gene which might be responsible for different clinical phenotypes, or there would be a genetic heterogeneity where you have a same phenotype like retinitis pigmentosa or congenital deafness, but you know there are hundreds of genes which are involved in the same phenotype. So to know the exact etiology, you have to have a molecular diagnosis, irrespective of whether your clinical diagnosis is confirmed. More so now because of the era of personalized medicine, precision medicine, where the therapy is dependent not only on the clinical diagnosis, but also dependent on the variant you have detected. For example, in DMD, where there is exon skipping going on, there are various trials going on, and FDA has also approved. We need to know that whether the deletion in the child with DMD would be validated to go forward for the treatment. Similarly, for spinal muscular atrophy, when we are having a treatment, but they want to know the ratio of SMN1 is to SMN2 genes. So in such conditions where there is precision medicine, you have to know the exact genetic etiology. More so for expanded carrier testing or for prenatal diagnosis, we know that molecular diagnosis is warranted. So everyone, I had a few questions in which they asked that what is exactly the diagnostic yield of NGS? How many times do you miss variants, or how many times, in spite of a very good genotype, phenotype, you are not able to get a molecular diagnosis? So the diagnostic yield again will be based on the phenotype. Even in the phenotype, it would be based on what panel or what testing you have ordered for that particular genetic disorder. So just taking an example of a panel-based test related to primary immunodeficiency, we just analyzed few cases over the past few years. And if we say that the diagnostic yield just consists of the pathogenic and likely pathogenic variant, we can see that the yield is not very high. It could be anything between 25 to 30%. Along with that, if you can see that the VOUS is also an equal amount, and still none cases are also almost like 50%. So the diagnostic yield depends on the underlying phenotype. More so, it also depends whether you are testing just the proband versus whether you are diagnosing along with some familial samples or even just a trio. So irrespective of the phenotype, we analyzed around 14,000 plus samples, and we found that the diagnostic yield for NGS is, if we consider only the pathogenic and likely pathogenic variants, is around 35-36%. And none cases would be higher. VOUS forms a very big chunk, mainly because of multiple reasons, which I will be taking on in the next few slides. And when we choose to do a trio or we use multiple affected, unaffected family members, the diagnostic yields jumps up to 60%. So this is done in a very few samples, but probably we can explain this in a better way, that why a trio or a family analysis will improve the diagnostic yield. So for inherited mutations, you may have either the autosomal recessive, X-linked recessive, or autosomal dominant form of diagnosis. So on autosomal recessive condition where there is no consanguinity, you have two affected members, then when we do a combined analysis of both the affected, the unaffected, or the parents together, we have a confidence that we are searching for compound heterozygous variants in both the affected siblings, and the same heterozygous variants should be present in heterozygous form in the unaffected parents, and possibly the unaffected person should not be having those variants. So in one go, we, instead of a VOUS, a variant which is common in both the affected, not there in the unaffected, and present in heterozygous form in the parents, would help us classify the variant as likely pathogenic and sometimes even pathogenic, rather than if we do just one affected patient proband and give it as a variant of uncertain significance. Similarly, in consanguineous marriages, or where there is a high form of inbreeding or in some communities, then we can see that there are two SIBs affected and they would be having homozygous variants and the parents would be heterozygous. So in one analysis, we can get a higher yield compared to doing a proband. Similarly, for X-linked recessive, though the pedigree, 3-generation pedigree would give you a clue, we can have the similar way that the X chromosome variants are there in the carrier females and the affected males are having the hemizygous variant of the same gene. Similarly, in autosomal dominant, if you have a vertical form of inheritance patterns, then all the affected member would be having the heterozygous variant, but the unaffected will not be having those variants. So there is nothing common between the affected and unaffected. So this works as a case control study, that all the affected are having a particular gene, a variant, and the unaffected will not be having it. The same applies even for de novo, like even if it is a de novo and we have multiple different families in which the clinical phenotype is very clear and all the affected probands are having a single similar variant compared to the people who are not having it, then in one go again we can confirm that it is a de novo dominant variant. Similarly, we can also apply the same principle to doing multiple tissues testing. This holds good for overgrowth syndrome, neurocutaneous, where we have mosaic pattern of inheritance and we cannot have a single gene. So the affected and unaffected tissues can have different variants which will help us confirm the gene or variant of interest. So in spite of doing this, I will not go much on the positive reports. I want to focus on when we have a negative report or a variant of uncertain significance, because direct cases and where you find a very good genotype phenotype, it's easy and we can give a positive report. But we are more concerned that once there is a particular phenotype, and we are getting a negative report, what else can be done to analyze further? So as I have discussed in the previous slides, there could be mutation in other genes which are probably not covered if you have sent a panel, or it may not have been covered in the clinical exome, or probably you are looking at mitochondrial genome is tested differently, or sometimes we may get a gene even if you do a whole exome, but it does not have a very clear-cut OMIM phenotype of literature evidence, and in such situations the report might either be negative or you may get a variant of uncertain significance. Now there are conditions when there are deletions, duplications, which may be the primary mode of or mechanism of pathogenicity in those genes, for example DMD, or microdeletion, known microdeletion, microduplication syndromes like Angelman, Prader-Willi or Dye-George. In these, it is known that NGS won't be the first step of testing, but MLPA is a better choice because again, we are looking at something which we know. So for DMD or SMA or microdeletion, microduplication, subtelomeric deletion duplication, we would prefer doing an MLPA. We can always know our gene of interest, whether deletion duplications are more common or sequencing is more common, by going to gene reviews or other literature reviews and understand what would be the first step. Or sometimes for unknown microdeletion, microduplication, chromosomal microarray is a better choice rather than going for NGS. I have informed last time also that in the newer pipelines or better bioinformatic algorithms, we can detect CNVs. Sensitivity, specificity might be as high as 75%. Pickup rate has definitely increased, the diagnostic pickup rate for certain genes where we get single heterozygous CNVs, and hence we can do that also, but still being in the validation state, we need to confirm whatever we get by alternate methods which are more gold standard. Sometimes deep intronic promoter regions are not covered in the whole exomes, clinical exomes and panels. But again, as I've told, that in the newer versions of the updated exomes, the reported functionally validated deep intronic variants might be covered in them. So the pickup rate has definitely increased. But if you have done a report maybe in 2016, 2017, since this updated databases are post 2018 or early 2019, you may have to do a reanalysis of the data. Sometimes the data has been run on a smaller panel. We may or may not be able to do it with the newer panel, so we may have to repeat the whole test again to get a better result. Most important of all, again, does the gene or the variant which has been reported, is it matching your phenotype? Many times the phenotype provided to the lab may lack certain features which are there in the variant which has been detected. And so because of lack of phenotype, either the variant is classified as a variant of uncertain significance, or it is not even reported, just sent out in a mail asking for a correlation. The unfortunate part is that sometimes these mails may go to the primary clinician, and in that time the patient may go to some other clinician for a second viewpoint, and the initial correlation may not often be can be confirmed. And so it is like sometimes the report keeps moving on as a variant of uncertain significance or a non-report. So once you feel that in spite of a good phenotype what you have given, you are not able to get a significant report, there are certain steps which can help to get a little higher yield. So either you do a clinical evaluation or you do a reverse phenotyping. Reverse phenotyping is whatever gene of interest or variant has been given in the report or via email, whether you need to recall the patient and compare the genotype with the phenotype rather than the phenotype which you had and the genotype which is gone. Sometimes you may have to do additional tests for confirmation wherever possible. So for example, if you get a gene which has additional biochemical test, you can always perform those and confirm whether it is possible. Example, if you are suspecting cystic fibrosis and it comes as negative, and a gene which causes primary ciliary dyskinesia is reported for your patient, then a lung biopsy to confirm PCD is a possibility, and it can reconfirm your diagnosis by an additional test. Sometimes there is improved pipelines, new literature coming in, daily new genes, new variants are being reported in literature. So if it is a 6-8 month old report, then you can always go back to the lab and help them with some additional findings, because in 6 to 8 months, probably sometime there is a changing phenotype. So you can give the additional details, and reanalysis request can be given, so that based on these new literature or improved pipelines, either your variant can be reclassified. We have seen where VOUS is a variant of uncertain significance has been reclassified to likely pathogenic, and sometimes it has been reclassified to benign or likely benign and removed from the reports. So both ends are possible for a variant of uncertain significance. And as being emphasized again, parental testing or what is called a segregation analysis is important. Many times we feel that we have done the parental testing, then the classification should change. But what exactly is segregation analysis is we have to do it in affected, unaffected, other members also. Again, the situation is nowadays we don't have such large families. We have just one affected child and no other family member affected in 3 generations. So probably we may not get many samples for affected, unaffected. So in that case, the next best step is to do a parental testing. In few cases, just doing this will reclassify. So even after all this, if it's not possible, then probably you may have to go for whole exome. As I said, try a whole exome has a better pickup rate. And then lastly, probably the last would be on what we can rely is whole genome. So just I would like to discuss 7 or 8 cases, few of them very fast, 1 or 2 in detail, just to give you the emphasis is that how a non-report or a variant of uncertain significance can be changed to a significant report. So here this child was suspected to be affected with Marfan syndrome based on the clinical criteria. So mild motor delay, subluxation of the lens, and high myopia. So based on this, they sent for single gene FBN1 causing Marfan syndrome, and no significant variant was detected. It was then extended from single gene to clinical exome sequencing, and we found a homozygous variant, a likely pathogenic one, which causes homocystinuria with or without response to B6. So this is a CBS gene which causes homocystinuria. So, and as clinicians, we know there is a overlap between Marfan syndrome and homocystinuria, including variable intellectual disability. Marfan syndrome usually doesn't have much of intellectual disability. But the importance of doing testing further is that 50% cases may respond to B6. So the treatment also changes once you have a good clinical confirmation of your phenotype. Similarly, this was extended from a panel to clinical exome. This baby was suspected with Barter syndrome, typical symptoms, polyuria, polydipsia, alkalosis, and seizures. But no variant was detected in the Barter syndrome or Gittelman syndrome panel, which has 8 genes. So they requested for reanalysis, again suspecting either tubulopathy or East syndrome. And what was detected was compound heterozygous variant in cystic fibrosis gene. And as clinicians, again, we are aware that cystic fibrosis does mimic Barter syndrome. It is also known as pseudo-Barter syndrome, and they may have a very similar clinical phenotype like Barter syndrome. So it becomes important that based on your phenotype, whether you want to send for just a single gene, a panel, or clinical exome. So it's always better to ask whether your gene of interest or differential diagnosis would be covered in that smaller gene panel. When a non-report is there and we have a step of going forward, but sometimes in spite of doing a clinical exome, we get a variant of uncertain significance, and probably this is much more annoying than a non-report because we have something but we can't do anything about it. So this becomes very important, that what to do next. So this was a primary immunodeficiency. We got a single heterozygous variant. It was given as uncertain again because of the ACMG guidelines, that it was a missense, not reported, partial phenotype match, because this immunodeficiency type 13 probably did not have T minus B plus NK negative type of skin pattern, but it just is associated with immunodeficiency. Unfortunately, this child succumbed to the illness. He had also undergone cord blood stem cell transplantation. Now moving forward, this family came for carrier screening because they wanted to plan another child, and it was from a different clinician. On carrier screening, the couple was found to be carrier of not one but two variants. One was pathogenic in MTHFD1, which again is causing combined immunodeficiency with or without hyperhomocystinemia. But since the child was not there, probably this could not be confirmed by biochemical means. But the other variant was also good. It was a likely pathogenic variant causing T cell negative, B cell negative, NK positive skin. So this is most likely to be matching. Now, when the parents were sent for carrier screening, we also analyzed it along with the proband data. This was not sent for trial, it was sent for carrier testing. But since we had the proband data, we did a trio analysis, and the UNC 119, which was found in the proband, was found in the mother also. So this variant, autosomal dominant single heterozygous, was ignored. The second variant, MTHFD1, was not found in the proband. So probably this was also not the gene of interest for this child. But you can see that if parents are carriers of this gene, which is pathogenic, in the next pregnancy, there is a 25% chance that the fetus would be having these variants, or he may be having this variant again. So by carrier screening, we came to a diagnosis that this child had RAC2 mutation minus 28 G2T and a likely pathogenic variant. Literature search confirmed that is a reported deep intronic. Now again, why was it not reported? This was a big thing for us, that how did a homozygous variant not reported previously? It was because again, it was an off-target variant. It was a minus 28. And as discussed previously, when you use the filters, deep intronic variants were initially being filtered off, and more so because the depth was 8x. The minimum depth which we consider would be at least more than 20x for homozygous variants. So probably because of that, this homozygous variant was filtered off. But after drawing trio and seeing the same variant in the parents also, it was confirmed that this child was a homozygous gene of RAC2 mutation. Now, CNV analysis. Everybody is interested in knowing that how NGS can now pick up heterozygous variants, which are copy number variants and not single nucleotide variants. So this is again in silico copy number variant analysis. So when it is a large deletion, multiple exons are deleted, and if it is matching a phenotype, then NGS, if done and with the help of the bioinformatic pipelines, we do report heterozygous variants, CNVs also. So we can see that TCOF1 causes pressure colony type 3 and large deletions have been reported. So when we want to report a CNV heterozygous, we also want to know whether this mechanism is reported in that particular gene or not previously. So in certain cases, deletion duplications till date have not been reported. So we cannot, as lack of literature, we cannot report them as likely pathogenic. Probably it would go out as a variant of uncertain significance. So using certain pipelines, we are able to now detect CNV, single heterozygous copy number variants, and this has increased the yield by 15 to 18% in our clinical NGS reports. But again, as I said, that these have always to be validated by an alternate method. So this is MLPA, which confirmed the deletion of the 7 exons of TCOF1 gene. Now, certain MLPA probes are already available because they are very commonly found and requested for. But certain probes for very rare disorders have to be ordered from MRC Holland, and only if we have adequate MLPA probes available for that gene do we confirm that let us do MLPA. If MLPA is not available, then again we may have to go for alternate methods like I told before. It could be chromosomal microarray or exon array, PCR based methods. So there are different methods based on how much part of that gene is deleted or duplicated. So for homozygous or hemizygous deletion, it is much easier to report because it is clear on the IGV. So here you can see when you compare the coverage. So you can see the exon coverage. These are the exons of this CYBB gene. And you can see that there is a large area which is not at all covered in this sequencing. So when we compare it with 2 other samples simultaneously run in the same library or preparation, we can see that this is not covered well. So we are confident in confirming that this is a hemizygous, sorry, this is an X-linked gene. So it will be a hemizygous deletion, but the same coverage can be seen for homozygous. Now I'm coming to deep phenotyping and reanalysis. Here we had a child, 4-month-old, who was referred for arthrogryposis multiplex congenita and multiple bone abnormalities. There was a family history that the elder female sibling had died of a similar illness. No other clinical information was given. We checked for all genes which cause arthrogryposis multiplex. We checked for skeletal dysplasia, bone abnormalities, a combination of both. But unfortunately, we did not get any variant. Now, when it's a non-consanguineous marriage and there are 2 SIBs, we have as a clinician, I feel that we should get something, right? So we just requested them that if we could get any more additional details. But unfortunately, even this child had succumbed to the illness till we could get back. So we requested that let us do a genetic counseling session with the parents, and one of our genetic counselors called up the mother. We took a 3 or 4 degree pedigree, and we found that along with these 2 SIBs, there were 2 cousin siblings also who had expired because of developmental delay and dystonia. Now again, because with additional findings, we also requested her if she had any photograph. And when we saw the photograph, there was mild dysmorphism. There was definitely overlapping of the fingers, fixed flexion deformity. The mother said that when the child was asleep, she was much more relaxed, but he couldn't move his hands or legs much. So we also requested for a video. I hope all of you can see this. So there was increased tone when the child was crying. There was a huge umbilical hernia, bilateral inguinal hernia, and an abnormal cry. So this was probably not simply arthrogryposis, but arthrogryposis along with dystonia plus inguinal hernia. So based on these additional findings, we reanalyzed the data and we found two variants in TOR1A gene. As you can see, the first variant is a heterozygous variant, missense. The depth is quite good. MAF is 0 in all the public databases. Internal database also it has not been reported. And it is damaging by all the 4 in silico prediction tools which we use. The second is also missense splice-side proximal variant. Again, 0 MAF and damaging by all. And what we know about TOR1A is that it is a autosomal dominant type of a condition which causes torsion dystonia type 1. It also has incomplete penetrance. So an autosomal dominant gene with an incomplete penetrance could be an associated gene with this. And when we had the OMIM entry, you can see that it is still reported as autosomal dominant. They have still not mentioned as autosomal recessive form till date. And it causes what is known as dystonia musculorum deformans type 1. And you can see the edit history. It is May 2018. So we have to search literature more. And recently we found that there was a paper which said that biallelic TOR1A mutation caused severe arthrogryposis, and they also had referred it as a case of reverse phenotyping, and was reported in September 2019. So very recent paper. And if you see the phenotype, it matched perfectly. The overlapping fingers, the facial dysmorphism, and as you can see, the patient also had large ears, umbilical and bilateral inguinal hernia. So it's very interesting to know that what we have found is confirming something reported in literature. So it is not an autosomal dominant, but probably it should also now be referred to as autosomal recessive inheritance pattern. But it is quite exciting, but also, sometimes depressing that if we put this in ACMG, it would be classified as uncertain. Why? 2 reasons. Firstly, this case had shown 6 cases in which 4 of them were all termination variants and other 2 were also homozygous, and hence as per literature, termination mutations variants are reported more and homozygous are reported. They had not reported any compound head. So literature was lacking, and more so because there are 2 variants, we need to do it in the parents to know whether it is compound head or or it is in the same allele. So this becomes important that, okay, once we do the parental testing, since we don't have the other siblings DNA stored also, it becomes important that at least based on the parental testing, we would reclassify it as likely pathogenic, if not pathogenic. So just again reviewing the same molecular testing algorithm, even for NGS, along with NGS, if we are complementing it with a CNV analysis, even that is negative, then we may have to go for a trio, whole exome or whole genome. And only after that is negative, we may have to go in for a genome, which everyone says that since it is available, it is better to go for whole genome. But genetic diagnosis, like all other clinical diagnoses, should always be a stepwise approach. So the most important thing is sometimes when we have a critical patient, we are not sure of the prognosis. We are not able to give a management option. The parents may not be ready for doing further testing. Many times they say, no, we are not planning any more children, so we don't want to do, or if the management is not going to change, why should we spend so much more money? So in this also, the only recommendation is don't let the DNA go. Store the fetal DNA. In future, probably the parents may change their mind, if not for them, if for extended family member or for their other kids who may be of a marriageable age. So it's always better to store all the medical records, take a clinical photograph and store the fetal DNA. Example, this child, prenatal diagnosis was done, possible because the first child was unfortunately not worked up, but when the second child was worked up in Mumbai, they did an enzyme analysis and they said that it might take 7 or 8 days. So they were going back to Rajasthan, and on the way, the child got critical and was admitted in a small town hospital. And the only advantage was the parents agreed for DNA storage. And on the way back home, they lost the child. But in the meantime, the enzyme analysis came, and based on the stored DNA, we could confirm the diagnosis of Niemann-Pick disease by doing this testing. And then we coordinated, and the prenatal was done in Jaipur itself. So now it's becoming easy to coordinate between labs, between clinicians. Logistics is becoming easier. So a child worked up in Mumbai, DNA stored in Surat, and being tested in Jaipur, right? So everything can be done, and they have now done a prenatal and they have a normal female child. So prevention of genetic disorders now becomes always a secondary prevention. You always have somebody else, there is a one person affected and he wants to know the risk in his children, so he wants to get tested, or the first child is affected and they want to know the risk in the second child. There is consanguinity, multiple affected children, or they want to know their risk in X-linked disorders also. But there are situations in which you may not have a genetic history, but since the couple is marrying late, they want a small family, probably only one child now, so they want to do everything to know whether they are at risk of having a child with any genetic disorder is their concern. And they usually say that in our 3 generations we don't have anybody, but yet we want to get ourselves tested. And we do get samples like this pre-conceptionally, but also pre-marriage. So do we have an option for them? For example, in this family, they are consanguineously married. There is no history suggestive of single gene disorder. Now, diabetes or myocardial infarction, hypertension, these are complex disorders. We don't test for them. Being multifactorial complex disorders, they cannot be used for a final Mendelian sort of a diagnosis and doing a prenatal diagnosis in them, because they may be susceptibility genes. A patient may have the variant but never get the disorder. So in such cases, we specifically tell that we will be testing for autosomal recessive disorders or X-linked recessive disorders, and pathogenic, likely pathogenic variants might be informed to you. So in this couple, consanguineous marriage, you can see that they were carriers of not one, but 2 likely pathogenic variants. One in methylmalonic aciduria and other in cystic fibrosis. And as you can see, the gene is same, but the variants are different, right? So this is in exon 6, this is in exon 10. So it is not always 100% that being a consanguineous marriage, you are going to get the same variants in both the alleles. So here there is the same variant and same gene. So CFTR, exon 4, same variant. So mostly we think that it is always, if there is consanguinity, both of them should be carriers of the same variant. But we have seen many cases in which they may be carriers of different variants in the same gene. So it becomes very significant to inform them about this. So coming to a clinician's role, you are the first point of contact. You have a good rapport with the family would listen to you. So whether your child or your patient needs to have further analysis by any other subspecialty, it could be a detailed ophthalmic evaluation, it could be a repeat MRI or MRS, or getting a confirmed dermatology opinion, they will listen to you. You will be reinforcing the genetic counseling, whatever is done to get a good diagnostic yield. And often it is that rather than give a wrong diagnosis based on lack of information, it is better not to give a diagnosis at all. We can just give a good medical record, a good HPO terms related summary, and some differential diagnosis so that they can store it for future reference. To summarize is that it is coming up in a big way. Multiple companies are coming up. The costing is going down. Logistics are improving. But we all have to know when to order, what to order, and where the test should be sent. And when you receive the results, how to understand or interpret the contents of the report. You have to understand the clinical validity as well as the clinical utility and whether it is likely to benefit the patient. Along with ethical consideration, now medical legal considerations are also very, very important. They are aware of their rights. Doing a test versus not doing an available test, both can cause trouble. So pre-test, post-test counseling, written informed consent is very important part of genetic testing. So before I go to the questions, I would just like to acknowledge all my clinical collaborators. I have shared many reports and many of them are from very close. I can consider them as colleagues and families who have been supporting us for a long time. And my whole team of MedGenome, there are people from whom I'm learning day in, day out. And there is not one day when I can feel that now I don't need to learn anything more. Every day is a new day. And definitely my approach to genetics is totally, I dedicate it to Dr. Shubha, my teacher and guide. So now there were a few questions in the previous presentations, which I'm trying to cover it a little fast today. So in spite of this, besides this, if you have any more questions, you can just put it out on the Q&A section. I'll take them after this. And if they have already been covered and you want it again, you can mention it. So is mitochondrial genome covered under whole genome sequencing? So the answer is yes. Whole genome will cover even the mitochondrial genes along with the nuclear genes, but the coverage of whole genome varies between 10x to 50x. Though a uniform coverage is 30x, yet for mitochondrial genome, to detect the alt allele percentage, the average depth should be at least 500x or higher. So in whole genome sequencing, since we have not done many cases for this, I am not the right person to share my experience, but we can always look out for them. Then the question is what to do when a gene of interest has a pseudogene while doing NGS. So one thing is, before sending for NGS, if we are aware that there is a pseudogene already, then we recommend going for alternate tests. For example, SMN1, SMN2, they are almost like different only in exon 7 and 8 by 2 nucleotides. So SMN is just, I think, less than 4 or 5% covered in the NGS. So directly we have to go for MLPA. Similarly, for CYP21A2, which has multiple pseudogenes, we recommend directly going in for a panel or a combination of sequencing and MLPA. But while doing NGS, if the target area in the gene of interest has pseudogenes, the variant is picked up, we do report it, but we always recommend that a Sanger has to be done to prove whether it is false positive or is true positive. So there are certain genes, I can give an example of PRSS1, in which the alt allele percentage was always very high, like 58%. And when we tried to do 10 of these samples, in 8 of these samples, it came out to be a false negative. So it is because of pseudogenes that the alt allele would sometimes go spuriously high. So in such cases, we can always recommend doing a Sanger. How to know whether a gene has a pseudogene? Well, there are various, not various, I would say 2 or 3 databases. In pipelines, they are included already. So the bioinformatic analysis pipeline tool already has it, but you can always download it from pseudogene.org or genecast.org. So these are 2 or 3 databases which can give information whether your gene of interest has one pseudogene or multiple pseudogene. Second, another question was whether IGV is a software and needs to be downloaded. So the answer is yes. It is a software by Broad Institute. So it can be downloaded from the Broad Institute website. In indels, how many bases are deleted or duplicated? So indels can be as low as 2 base pairs to as high as like 80 base pairs, but in NGS with confidence, if we want to report, then it can go up to 10 base pairs or 25 base pairs So from 10 to 25 base pairs, we can very well with confidence report it in NGS. How much minimum depth has to be there for SNP or indel to report? So, minimum is, we can take, minimum can be anything, but 20x to 30x is what is our cutoff. But if it is a gene of interest, good phenotype match, along with, like if it is MORQ and you have done the enzyme analysis, then we can remove all filters also and check it. And even if we get a 4x, 7x, then we can do an internal validation, we can do a Sanger confirmation, and it can be reported. So again, if it is low depth, it has to be confirmed. For somatic mutations or variants, the depth should probably is more than 1000x, right? So minimum Agilent Sure Select kit is for whole exome, and it is supplied by the Agilent company. What are the methods to detect large deletion duplication? This I think I have already dealt with in the previous slides, but as I can say, you can do MLPA, you can do microarray. Microarray again would be, you can do high definition or 750K or exon array for 2 or more than 2 exons. So it depends on how large is the deletion duplication which has been picked up in NGS, but it can also be dependent on whether the primary mechanism is a deletion duplication. So there are different methods. For known, we have MLPA, for unknown, chromosomal microarray. This can be taken as a. Can NGS pick up large duplication? Again, I have covered it. Yes, we can pick up large duplications and deletion. Could you explain what is the difference between mutation, variant, SNP, and allele? And how do you check whether compound heterozygous variants are in cis or in trans? So this I wanted to take up because it is very important again. So as I discussed in the previous presentation, variant is anything different from your reference. So there is a reference sequence which has A, right? Anything, any variation from A would be a variant. So polymorphism and mutation, as discussed, were taken up previously. Polymorphism is more common in the population. We can take the cutoff as 1%. Mutation is a rare variant, and it is more likely to be causative of a pathogenicity of the variant, and hence it is mutation. Many people take it as interchangeable, but we can stick to variant to be specific. And what is allele? So in a chromosome, we have a gene at a locus, and there is a particular allele or a reference allele, what we can say, and any variation from that is on the other part of the chromosome or the second chromosome will be taken as allele 2. So if allele 1 from one parent is having A, then the other chromosome from the other parent can have the same allele, so it will be a wild type, or it can have a different allele. So if one chromosome of interest has the reference allele and the second has a different, then it would be a compound heterozygous. So to prove compound heterozygous, we have to see whether, now compound heterozygous would be when the same gene has 2 different variants. So we have to see whether those 2 variants are very close to each other and are coming together. So they will be in cis. So they will be on the same chromosome coming from the same parent. But when in trans, each will be coming from 2 different parents at the same locus. So this is what will be known as compound heterozygous, when 2 different variants are found. But if they are found in cis, they have to be ignored and they will not be considered as compound heterozygous. They are just like they are running together on the same gene or loci. I hope I am able to clear this as much as I could. This is more of a clinical query, I suppose. And suppose a patient is harboring a homozygous mutation and there is a clear genotype-phenotype correlation. Do we need to do parental segregation even if they don't want a second baby? So this is a very practical question, but again, to be correct, I would always suggest that whether it is a homozygous mutation or a heterozygous mutation, you should do a parental segregation. So in homozygous, one thing which probably can be missed by not doing parental is whether the other allele has a deletion. So if one allele has a mutation and the other allele from the other parent has a large deletion, it might be interpreted wrongly as a homozygous mutation. So just to rule out that, it is always better to do parental segregation. Sometimes I myself have seen in 2 or 3 cases in which one of the parent, though asymptomatic, were having the same homozygous mutation and the variant had to be ignored. So yes, parental testing is always advantageous. Another scenario, a heterozygous pathogenic variant is identified. There is a phenotype correlation, but one of the parent is having the same mutation but is asymptomatic. So such situations are seen in autosomal dominant inheritance patterns where there is a concept of incomplete penetrance. So incomplete penetrance is also reported for many genes. So we have to go back to literature and search whether that particular gene has a concept of incomplete penetrance and how much percent. Some genes have an incomplete penetrance of as high as 30 to 40%. It means that in spite of having the variant, 30% or 40% of the persons who are having that variant may never be symptomatic or they may be very mildly symptomatic, right? So in this case also, even if it is a pathogenic variant and one of the parent is harboring it, we may have to reevaluate the parents also clinically. Sometimes if as per literature, incomplete penetrance is not reported, the pathogenic variant can be reclassified as variant of uncertain significance. This retrograde reclassification has also been seen. Another which he has asked is, for a homozygous or a compound heterozygous VOUS, we advise parental segregation. Both parents harbor the heteromutation. Genotype-phenotype correlation is there. Can be classified as likely pathogenic. So yes, just like I explained in the TOR1A variant, if it is a very good variant based on the predictions, on the minor allele frequency, on the literature evidence, this variant would be classified as likely pathogenic. Again, after the segregation studies, we may have to again go back to ACMG and choose the segregation classification, and then it can be reclassified as likely pathogenic. And similarly, he has asked that for same way, if it is a VOUS in index, parents are negative, so mutation is de novo. Can we call it as likely pathogenic? Here there is a little, I would say we have to be careful before calling it likely pathogenic, because if there is evidence good enough and just because the variant has to be de novo, we can classify it as likely pathogenic. But if there is a situation in which there are, like again, as I told, variable phenotypes and we don't have good evidence and it is a missense variant, like for DMD gene, which is X-linked, but still I'm just giving an example. If it is a huge gene, so there are high chances of it having missense variants. So every de novo missense variant cannot be like by default be called as likely pathogenic or pathogenic. We have to search for literature to give it significance. So I would like to thank everyone again. Knowledge is definitely paralyzing. I really love this slide. That the more we know, the harder it is to take a decisive action. And I think this holds true for every clinician. That nothing is as clear and simple. We felt that as soon as NGS comes now, certainly 100% we are going to get all answers for all our rare disorders. But it is really that we are just still at the tip of the iceberg. We really don't know a lot of things. And as I said again, that it should always be a stepwise approach. It is always that if we are suspecting, how much further you can go for that, for confirming your diagnosis. Thank you. So I'm just going to the question answer. There will be very personal, like case related. I think I will not take them. You can always email it and I'll get to them personally. Sanjida had asked, please explain about repeat expansion. So I had taken it in the last session, but just a few words I can say that repeat expansions are triple repeats. Almost more than 40 disorders have been known. It is a non-Mendelian mode of inheritance. And these are just repeats which occur more than a particular set of times it should be to cause a disease. And if you want to know whether NGS covers it, that I've taken that NGS is not going to cover triple repeat expansions and an alternate method is there. So there is a question that there was a child with autosomal dominant SCN2A mutation. The same was present in the child and father. Father had episodic hemiplegia and the child had episodic ataxia. So what are the causes of varying phenotype with the same variant in genotype in different individuals of the same family? This is a really good question, but many times the answers are not very simple. The only thing is there are many modifier genes. So it is not only the gene which is going to play a part, but the gene is then transcribed, translated, and there are other modifier genes which may be different in the child and the father, which can differ the phenotype. So in the same family, the same genotype can cause a milder disease, and in the other person it can cause a severe disease like tuberous sclerosis or neurofibromatosis. So it's the same, that it depends on how much that mutation is causing a effect in which system. So whether a modifier gene is decreasing the action of that mutation in some other system. So this is the mildest way I can describe that, but for individual mutations, there could be literature in which somebody has done some more work and we can get answer. How to approach a child with reported as compound head? I have already told, we need to do the parental studies. Does mito whole genome cover nuclear mito? Yes. No. Mitochondrial genome sequencing. So this is a confusion. They have asked mito whole genome. There is nothing called mito whole genome. So mitochondrial genome sequencing will not cover nuclear mitochondria. That is what my answer would be to this question. Can we do prenatal testing on the basis of VOUS? Obviously, there is genotype correlation and there are surrogate markers retrospectively found. Again, this is a very risky decision to take. We do not recommend prenatal testing based on VOUS. But yes, if the VOUS is slightly significant just because we have not confirmed it based on lack of information, and rest of the things are falling in place, we have to do a pre-test, post-test counseling. The gene may be good, but the variant may not be responsible. There could be some other variant. So when you're doing a prenatal, we are just doing Sanger for one variant. So you have to be very specifically do a pre-test counseling that we are testing only for this variant, which might be responsible for the disorder. So to take, to take such reproductive decisions based on VOUS ideally should not be recommended, but based on case to case, we can take individual decisions. What is the difference between mutation variant? I have already covered. Even if we are doing prenatal diagnosis, should we do Sanger confirmation for pseudogene? I did not get this question. I think for prenatal diagnosis, it is more important to do Sanger confirmation because we have to take a likely significant decision. So irrespective of whether you are doing a normal testing or a prenatal, I think for prenatal becomes much more important to do Sanger. What is exonic array? What are its indications? This is a different topic. Probably we will take chromosomal microarray in some webinar and we can cover it. Which are the institutes which do functional studies? Unfortunately, I am not the right person to answer this. Some research-based institutes we can ask. Overall, we can search to, like, some are gene-specific research-based labs, some would be phenotype-based research lab. We can always search and ask them. Which one is best technique for single gene disorder? There is no one best technique. Based on the gene, based on the phenotype, you may have to choose the best technique. How does in silico prediction results help in understanding the genetic reports? The in silico prediction results help to know whether the particular change in the variant is going to cause any significant change in the protein, or whether they are conserved variants or genes, and thus it will help in classifying the reports. And somebody has thanked me for the case-based discussion. Thank you, Dr. Priyanka. I think I have answered all the questions.
Preeta, I think we addressed almost all the questions.
Yeah.
And you know, if the audience has any additional questions, you can always write into us at diagnostics@medgenome.com or give us a call at 1-800-103-3691, and we'll be glad to have those questions addressed. And so once again, I'd like to thank Dr. Sheetal for taking time off and giving us this very informative session, and also answering all the questions patiently and diligently. And we will definitely be having more webinars in the future on chromosomal microarrays, on Sanger sequencing, and a whole load of other topics that we're planning out. So yeah, we'd definitely like to thank the audience for taking time off and you know, registering and attending this webinar. And we will definitely be sending out this recording in a couple of days' time, maybe a week or so. And as I mentioned earlier, we will also be having more webinars. So please do look out for the invitation to register in your email boxes. So, so thank you again, and we hope to see you next time.